Hello everyone, now let us discuss about 2023 coding guidelines, ICD 10cm coding guidelines for sepsis. In the current session, we will be discussing about coding for sepsis and severe sepsis, septic shock, sequences of severe sepsis, sepsis and severe sepsis with localized infection, sepsis due to a post-procedural infection, sepsis and severe sepsis associated with non-infectious process such as trauma, and sepsis and severe septic shock complicating abortion, pregnancy, childbirth and puerperal. Newborn sepsis, and this year's new addition is hemolytic-uremic syndrome associated with sepsis. This is the new guideline that is added from October 2022. Now coming to sepsis and severe sepsis, we will be discussing about what should be coded for negative and inconclusive blood cultures of sepsis, for urosepsis, sepsis with organ dysfunction, and acute organ dysfunction that is not clearly associated with sepsis. Now coding for sepsis. For a diagnosis of sepsis, assign the appropriate code from the underlying systemic infection. If the type of the infection or casual organism is not further specified, assign the code A41.9, which is sepsis unspecified organism. So for NOS of sepsis, the code is A41.9. And a code from subcategory R65.2, which is nothing but severe sepsis, should not be assigned unless severe sepsis or an associated acute organ dysfunction is documented. Severe sepsis code should not be assigned unless severe sepsis or an associated acute organ dysfunction is documented. Now coding for sepsis and severe sepsis. For sepsis, the NOS code is A41.9, and for severe sepsis, you need to first PDX is A41.9 plus R65.20, that is severe sepsis without septic shock plus any associated organ dysfunction. So severe sepsis usually contains minimum of two or more codes. Two codes are A41.9 plus R65.20, both should be given for severe sepsis, and if there is any associated organ failure, that organ failure code also shouldn't be given. Now next is negative or inconclusive blood cultures and sepsis and urosepsis. The negative or inconclusive blood cultures do not preclude a diagnosis of sepsis in patients. Negative and inconclusive blood cultures, they do not preclude the diagnosis of sepsis in patients with clinical evidence of condition. However, the provider should be queried. There is no specific code for negative or inconclusive blood cultures, and they do not preclude diagnosis of sepsis. In those cases, provider should be queried. And the next term is urosepsis. The term urosepsis is a non-specific term. It is not to be considered synonymous with sepsis. It has no default code in the alphabetical index, and should a provider use this term, he or she must be queried for the classification. So there is no specific code, it is a non-specific term, and it should not be considered synonymous with sepsis. You should not code sepsis for urosepsis. Provider should be queried. Next is sepsis with organ dysfunction. If a patient has sepsis and associated acute organ dysfunction or multiple organ dysfunction, follow the instructions for coding severe sepsis. For severe sepsis, as we have discussed earlier, two codes must be given. A41.9 for sepsis unspecified organism. Let us see an example. A patient got admitted for acute respiratory failure. Acute respiratory failure is the organ dysfunction due to severe sepsis. What are the appropriate ICD 10cm codes for this scenario? Codes for severe sepsis are first A41.9, that is sepsis unspecified organism. The next is R65.20, which is nothing but severe sepsis without septic shock. And finally, associated organ dysfunction. Acute respiratory failure is given by J96.90. Now coming to acute organ dysfunction that is not clearly associated with sepsis. Previously, the organ dysfunction is associated with sepsis. Now let us discuss the guideline when acute organ dysfunction is not clearly associated with sepsis. If a patient has sepsis and an acute organ dysfunction, but the medical record documentation indicates that acute organ dysfunction is related to a medical condition other than the sepsis. That is, it is not due to sepsis. Then you should not assign the code R65.20, which is nothing but severe sepsis. Whenever acute organ dysfunction is not associated with sepsis, then you should not code severe sepsis code. An acute organ dysfunction must be associated with sepsis in order to assign the severe sepsis code. If the documentation is not clear as to whether an acute organ dysfunction is related to sepsis or another medical condition, query the provider. Now let us discuss an example here. Patient has sepsis and acute respiratory failure due to COPD. Here sepsis is there and acute organ failure is there. But this acute organ failure is not related to sepsis. Acute respiratory failure is due to COPD. In this case, you should not code severe sepsis code. So first you need to code A41.9, that is sepsis unspecified organism, followed by J44.1, that is nothing but COPD exacerbation, and next J96.90 for acute respiratory failure. Now coming to severe sepsis. The coding of severe sepsis requires minimum of 2 codes, as we have discussed earlier. First, a code for underlying systemic infection, followed by code for subcategory R62, severe sepsis. If the casual organism is not documented, then you need to assign A41.9, which is nothing but sepsis unspecified organism for the infection, and additional codes for associated acute organ dysfunction are also required. Due to the complex nature of severe sepsis, some cases may require querying the provider prior to assessment of codes. As you can see, minimum of 2 codes plus associated organ dysfunction codes. Underlying systemic infection for A41.9 if it is unspecified, followed by R65.20 for severe sepsis without septic shock and any associated organ failure. For example, respiratory failure, renal failure, etc. Now coming to coding of septic shock. Septic shock generally refers to circulatory failure associated with severe sepsis. Here the acute organ dysfunction is circulatory system. Septic shock generally refers to circulatory failure associated with severe sepsis, and therefore it represents a type of acute organ dysfunction. For the cases of septic shock, the code for the systemic infection should be sequenced first, followed by R65.21, which is nothing but severe sepsis with septic shock, or code T81.12 series, post-procedural septic shock, should be coded. Any additional codes for other organ dysfunction should also be assigned. As noted in the sequencing instructions for tabular list, the code for septic shock cannot be assigned as principal diagnosis. This is important point. Code for septic shock cannot be assigned as principal diagnosis. That is, R65.12 cannot be assigned as principal PDX. First, it should be sequenced by systemic infection. Here you can see septic shock is nothing but severe sepsis with the circulatory failure. First, you need to code the associated systemic infection A41.9 sepsis plus severe sepsis with septic shock. R65.12 for general septic shock. For post-procedural septic shock, the codes are code for sepsis is the PDX, followed by post-procedural septic shock, which comes under the series T81.12. This code is further expandable. Now coming coming to sequencing of severe sepsis. If severe sepsis is present on admission and meets the definition of PDX, the underlying systemic infection should be assigned as principal diagnosis, followed by subcategory R65.20 as required by the sequencing rules in the tabular list. A code from the subcategory R65.2 can never be assigned as PDX. This is also an important point that we have discussed earlier. Severe sepsis cannot be coded as PDX. When severe sepsis develops during an encounter, that is, it is not present on admission, the underlying systemic infection and the appropriate codes for subcategory should be assigned as secondary diagnosis. Whenever it is present on admission and meets the definition of PDX, then first sepsis code followed by severe sepsis code should be given. Second scenario is severe sepsis develops during the encounter and it was not present on admission. In that cases, the underlying systemic infection and the appropriate code from the subcategory R65.2 should be assigned as SDX, not as PDX, because reason for admission should be the PDX in this second case. Here you can see the schematic representation. Severe sepsis is present on admission. In that case, sepsis is the PDX followed by code for severe sepsis. Second scenario, it is not present on admission but develops during the encounter. Then PDX will be the reason for encounter followed by systemic infection, that is sepsis code, and severe sepsis code as SDX. Now coming to sepsis and severe sepsis with a localized infection. This is next scenario. If the reason for admission is both sepsis or severe sepsis and a localized infection such as pneumonia or cellulitis, a code from the underlying systemic infection should be assigned first. That is, sepsis should be assigned first. Code from localized infection should be assigned as SDX. And if the patient has severe sepsis, a code from subcategory R65.2 should also be assigned as SDX. Here you can see two scenarios for severe sepsis or sepsis with localized infection. The first case is both sepsis and localized infection like pneumonia or cellulitis are reason for encounter. In that case, sepsis should be the PDX followed by code for localized infection and followed by code for severe sepsis and any associated organ failure if present. Next case is patient is admitted for localized infection. Here the reason for encounter is localized infection and sepsis does not develop until after admission. In that case, reason for encounter should be the PDX, that is localized infection should be PDX followed by code for sepsis and followed by code for severe sepsis and any associated organ failure. Now let us see an example. Patient presents with acute renal failure due to severe sepsis from Pseudomonas pneumonia. Here, Pseudomonas pneumonia is the localized infection and severe sepsis. Both are reason for encounter. In that case, first you need to give priority to sepsis code A41.52, which is nothing but sepsis due to Pseudomonas, followed by J15.1, which is nothing but pneumonia due to Pseudomonas, followed by R65.20, which is nothing but severe sepsis code, severe sepsis without septic shock, and finally acute renal failure code N17.9. Now coming to next guideline, sepsis due to post-procedural infection. Previously we have discussed about sepsis due to localized infection. Now we'll discuss about sepsis due to post-procedural infection. Documentation of causal relationship must be present. As with all post-procedural complications, code assessment is based on provider's documentation of the relationship between the infection and the procedure. Now for infections following a procedures, a code from category T81.40 to T81.43. Infections following a procedure, or a code from category O86.00 to 86.03. Infections of obstetric surgical wound that identifies the site of injection should be coded first if no. First T codes followed by assign an additional code for sepsis following a procedure T81.44 or sepsis following an obstetric procedure O86.04 and use additional codes to identify infectious agent. If the patient has severe sepsis, the appropriate code from subcategory R62.20 should also be assigned with additional codes for any acute organ dysfunction. Now let us discuss the subcategories of T81 series codes. The codes T81.42 and the OB code O86.02. They classify those post-procedural infections that are designated as deep in the surgical incision site, including the intramuscular abscess. And next codes are T81.43 and O86.03. They classify the infections, post-procedural infections that go into organ and space surgical sites, including but not limited to intra-abdominal abscess and subphrenic abscess. These are examples. So first these codes should be given, followed by codes T81.44 or O86.04 are usually used to identify sepsis following a procedure. Now let us discuss an example. A patient presents with fever, chills, elevated WBC and tachycardia with obvious left leg cellulitis. Here, left leg cellulitis due to previous removal of salpingeous vein for CABG. This has been an issue for several days and was extremely red and swollen. The patient was admitted to rule out sepsis and to begin IV antibiotics. The culture of the draining left leg and blood cultures were sent to laboratory for testing. This did show MRSA. The documentation does support that sepsis was ruled in. That is, patient was diagnosed with sepsis and after 6 days of IV antibiotics, the patient is ready to discharge. Discharge diagnosis is MRSA left leg superficial skin cellulitis due to previous surgery developing MRSA sepsis. Here this is post-procedural sepsis. So the first code is T81.41XA. Infection following a procedure, superficial incisional surgical site, initial encounter. Followed by T81.44XA. Sepsis following a procedure, initial encounter. And then A41.02. which is nothing but sepsis due to MRSA. Finally, L03.116, which is nothing but cellulitis of lower limb, are the additional STX. So in total 4 codes, T81.41XA, T81.44XA, which is nothing but sepsis following a procedure. Next followed by sepsis code A41.02 and finally cellulitis code L03.16. Coming to next guideline for infections following infusion, transfusion, therapeutic injection and for immunization. First a code from subcategory T80.2. Infections following infusion, transfusion, therapeutic injection or T88.0. Infection following immunization should be coded first. Followed by code for specific infection. And if the patient has severe sepsis, the appropriate code from the subcategory R65.20 should also be assigned with additional codes for any acute organ dysfunction. Now here you can see sepsis following infusion, transfusion, therapeutic injection. For sepsis following its infusion, transfusion or therapeutic injection, the first PDX should be from the category T80.2, which is nothing but infections following infusion, transfusion and therapeutic injection, followed by code for sepsis should be SDX. And the second case is severe sepsis following infusion, transfusion and therapeutic infection. This is for sepsis and this is for severe sepsis. If there is severe sepsis, like previously, T80.2 series should be coded first as PDX, followed by code for sepsis and followed by code for severe sepsis. and any associated organ failure also should be coded additionally. Next is sepsis following immunization. Here the PDX is from the category T88.0, that is infection following immunization should be coded first. Next followed by code for sepsis, and if there is any severe sepsis, R65.2 category code, and any associated organ failure must be documented or coded. Same, sepsis immunization, sepsis following immunization, and severe sepsis following immunization. Now let us discuss an example. Patient presents to ED with fever and not feeling well. Workup in the ED showed the patient has tachycardia of 112, high fever and not making sense when speaking. Patient was admitted with suspected sepsis due to central venous catheter that was being used for hemodialysis and also to rule out stroke. Workup did rule out diagnosis of stroke, but the patient was found to have positive blood cultures for streptococcal pneumonia. And the plan was long-term antibiotics and change of hemodialysis catheter. The patient was discharged with the diagnosis of sepsis due to infected hemodialysis central venous catheter. Now let us see the code. The first code is from the category T80.211A. That is nothing but bloodstream infection due to central venous catheter initial episode, followed by code from A40.3. That is nothing but sepsis due to streptococcus pneumonia as SDX. Now coming to post-procedural infection that has resulted in post-procedural septic shock. If a post-procedural infection is resulted in post-procedural septic shock, assign the codes indicated for above the sepsis for due to post-procedural infection, followed by T81.12 post-procedural septic shock. Do not assign code R65.21, that is nothing but severe sepsis with septic shock. For post-procedural septic shock, first you need to assign code from the category T81.40 to T81.43, which is nothing but post-procedural infection, followed by T81.44, which is nothing but sepsis, post-procedural sepsis, followed by T81.12 series, which is nothing but post-procedural septic shock and any associated organ failure. For post-procedural septic shock, you need to code T81.12, not R65.21, which is nothing but severe sepsis with septic shock. Now, sepsis and severe sepsis associated with non-infectious process. In some cases, a non-infectious process such as trauma may lead to infection which can result in sepsis or severe sepsis. If sepsis or severe sepsis is documented as associated with a non-infectious condition such as burn or serious injury and this condition meets the definition of PDX, then code the non-infectious condition first. If it meets the definition of PDX, non-infectious condition should be coded first, followed by code for resulting infection. And if severe sepsis is present, a code from the subcategory R65.20 should also be assigned with any associated organ dysfunction. And important point is it is not necessary to assign a code from subcategory R61.1, which is nothing but systemic inflammatory response syndrome or non-infectious origin for these cases. Now let us see an example. A patient is admitted with 3rd-degree burn of left lower leg and develops sepsis with septic shock. Here the reason for admission is non-infectious condition. So this should be the PDX. T24.332A, which is nothing but 3rd-degree burn of left lower leg, followed by sepsis A41.9, and finally sepsis with septic shock, severe sepsis with septic shock R65.21. These are the appropriate codes. Now coming to sepsis and septic shock complicating abortion, pregnancy, childbirth and Puerperal. One ground rule is whenever assigning the chapter 15 code for sepsis complicating abortion, pregnancy, childbirth or puerperium, the chapter 15 codes take the priority. That is, the codes take the first priority and they must be given as PDs. So you need to code O98.81 other maternal infections and parasitic diseases complicating pregnancy. This is further subcategorized based on the trimester. Or you can quote O98.82 other maternal infections and parasitic infections complicating childbirth. A code from the specific infection should be assigned as additional diagnosis. First you need to code O98.81 series followed by sepsis. And if severe sepsis is present, a code from subcategory R65.21 severe sepsis and code for any associated organ dysfunction are to be assigned as additional diagnosis. You can see for coding pregnancy, sepsis in pregnancy, first you need to code the series from O98.81 followed by sepsis code followed by weeks of gestation. If severe sepsis is there, you need to code additionally code from R65.2 and any associated organ dysfunction also. Now coming to puerperal sepsis. For puerperal sepsis, the code is different, that is O85. Should be assigned with secondary code to identify the causal organism, that is the causative organism, which comes under the category B95 to 96. And a code from category A40, streptococcal sepsis or A41, other sepsis should not be used for puerperal sepsis. This is important point. A code from category A40 or that is streptococcal sepsis or A41, that is other sepsis, they should not be used for puerperal sepsis. If applicable, use additional codes to identify severe sepsis, that is nothing but R65.2 and any associated organ dysfunction. Now let us see an example of sepsis complicating abortion. A patient is seen several days after a miscarriage with sepsis. The cultures return MSSC. The appropriate codes for this scenario are O03.87, which is nothing but sepsis following complete or unspecified spontaneous abortion, followed by B95.61, which is nothing but methicillin susceptible Staphylococcus aureus infection as the cause of disease classified elsewhere. Now coming to newborn sepsis or bacterial sepsis in newborn. For that case, category P36 bacterial sepsis of newborn should be coded and it includes the congenital sepsis. If a perinate is documented as having sepsis without documentation of congenital or community acquired, the default is congenital and the code from the category P36 should be assigned. If P36 code includes the causal organism, an additional code from the category B95, Streptococcus, Staphylococcus and Enterococcus as cause of disease classified elsewhere or B96 should not be assigned. That is, in the P36 category, some codes they describe the organism also. In that case, additional code for indicating the causal organism is not required. And if P36 code does not include the causal organism, assign an additional code from the category B96 and additionally, if applicable, use additional codes to identify severe sepsis and any associated organ dysfunction. That is given by R65.20. Now let us see an example. A full-term infant develops a sepsis 24 hours after discharge from the hospital and is readmitted. Cultures identified E. coli as infective agents. Here the appropriate codes are P36.4, that is nothing but sepsis of newborn due to Escherichia coli, E. coli, followed by, here the infant develops severe sepsis, R65.20, severe sepsis without septic shock. Now finally coming to the new guideline that is introduced this year since October 1st. Hemolytic-uremic syndrome associated with sepsis. Hemolytic-uremic syndrome associated with sepsis. If the reason for admission is Hemolytic-uremic syndrome that is associated with sepsis. Assign code D59.31 infection associated hemolytic uremic syndrome as the PDX, and the codes for the underlying systemic infection and any other condition such as severe sepsis should be assigned as SDX. Whenever hemolytic uremic syndrome is associated with sepsis, the PDX should be D59.31 infection associated hemolytic uremic syndrome, followed by code for underlying systemic infection and other conditions such as severe sepsis. Thank you for watching. Please subscribe for further videos on medical coding and CPC training.